afternoon, everyone. I am Dr. Gian Karlo Dadufalza from Philippine Orthopedic Center, and I'll be here to discuss on the role of limited decompression in adult spinal deformity. So I have no disclosures. For the outline of my talk, I'll be discussing the indications for decompression only in ASD, to compare the different available techniques, and to present some of my cases. ASD is a complex deformity involving the axial, coronal, and sagittal planes. By definition, you have to have at least 10 degrees of curvature on the coronal plane. And oftentimes, this is accompanied with degenerative chest pain, leading to a combination of back pain and radicular symptoms. So, the clinical presentation of ASD being a combination of axial pain, a presence of clinically evident deformity or evident deformity, but most often it is accompanied with neurogenic claudication and radiculopathy. The surgical treatment can be a simple decompression alone, decompression with limited spinal fusion, or the traditional long spinal fusion for deformity correction. So what are the indications of limited decompression in ASD? When is it safe to do a decompression alone? So the main indications are for radicular symptoms. So these are the patients presenting with leg pain, neurogenic claudication, and those with advanced age and medical comorbidities who cannot tolerate a more extensive surgical procedure. So we must remember that when you do a decompression alone, you must be aware that it may potentially destabilize the spine, leading to further mechanical instability and the subsequent need for fusion. However, doing a decompression alone, especially with the advent of less invasive techniques such as MIS and endoscopy, there is decreased surgical morbidity, less soft tissue injury, and faster recovery time. So traditionally, the conventional surgical treatment for ASD is known to have a high complication rate. So these are your fusion-related complications such as pseudoarthrosis and adjacent level disease. There's a long recovery period because of a more extensive surgery. And in our setting, there is a high financial cost because of the nature of the surgery itself, as well as the need for spinal fusion implants. So when can we do fusion alone? So in general, it is recommended that for mild deformities, so those with a Cobb's angle of less than 25 degrees, and in the absence of intervertebral segment instability, you can safely do a decompression alone without the need for a fusion. So what is the definition of instability? The following radiographic parameters are the criteria for instability. And the presence of more than 3 means that there's a potentially unstable spine, and it may be better to perform a fusion in these cases. However, in the absence of instability, decompression alone is a good option. So what is the best decompression procedure we can offer to our patients? Do we go with open, such as laminectomy, a laminotomy, or a fenestration, minimally invasive techniques using tubular retractors, or a full endoscopic decompression using the endoscope or biportal technique? So, is endoscopic decompression more effective than MIS in ASD? So in 2017, the group of Hofstetter did a study, and they compared 45 patients with combined lumbar spinal stenosis and adult spinal deformity. So they compared the outcome of unilateral laminotomy for bilateral decompression, or ULBD, using a full endoscopic technique, and an MIS ULBD using the tubular retractor system. And the outcome of interest was back and leg VASCOR and ODI at 2 weeks, 3 months, and 1 year post-op. And in this study, they found out that there was significant improvement in VASCOR and ODI in both groups. However, it is important to note that in the endoscopic cohort, there is significantly better early ODI, significantly fewer adverse events, and a shorter hospital stay. So for the first case, we have a 57-year-old male presenting with bilateral leg pain, and neurogenic claudication. At pre-op, the VAS score is 9/10 with an ODI of 47. So on radiograph, the patient presented with a 12-degree Cobb's angle on the lumbar spine and no radiographic evidence of instability. So on MRI, we can see a spinal stenosis and combined spinal and lateral recess stenosis at L4, L5, and on L5S1, lateral recess stenosis with a right-sided paracentral disc herniation. So this patient underwent a 2-level endoscopic decompression using the ULBD at L4, L5, L5S1 with a single incision. So in the video, we are at the contralateral lateral recess. So this step shows you the drilling of the contralateral SAP to decompress the contralateral traversing nerve root. So you can see that with the endoscope, you have superior visualization of the neural structures and excellent retraction of the nerve using the saline pressure. So this patient, post-op, you can see a 7-millimeter incision, and on radiograph, you can see evidence of good decompression, pedicle to pedicle decompression. Okay, so at 24 hours post-op, patient is allowed to go home without any assistive devices and no need for a brace. And at 2 weeks follow-up, there's improvement in the VAS score and ODI. Next case, we have a 37-year-old female presenting with right leg pain and right L5 weakness with an ODI pre-op of 41 and a VAS score of 9/10, presenting with a mild deformity with 24 degrees Cobb's angle in the thoracic and 21 on the lumbar, with no radiographic evidence of instability. So on MRI, the patient had a lateral recess stenosis bilateral at L4, L5 with a right paracentral disc herniation on the L4, L5. So this patient underwent interlaminar endoscopic lateral recess decompression at L4, L5 on the right side. So here we can see the drilling of the ipsilateral SAP to detach the lateral attachment of the ligamentum flavum and to decompress the ipsilateral nerve root. So this maneuver is done. The working cannula is rotated to retract the traversing nerve root and expose the ipsilateral disc. Here, the disc was calcified. There was no annular defect and no extruded disc material. So we just opted to do to cauterize the disc. So we did an annuloplasty for this case. Okay, and then this is the post-op incision, a 7-millimeter incision with a good pedicle to pedicle decompression. So at 24 hours post-op, patient is ambulatory and discharged with improvement in the pain. And at 2 weeks follow-up, there's improvement of the VAS and ODI. So in summary, with proper patient selection, you can opt to do a decompression alone. And patients with mild deformity and those without instability may benefit from doing decompression only. And we must remember that decompression will not address axial symptoms, and it's purely for radicular symptoms. And nowadays, less invasive techniques are available, which can safely decompress the neural structures, and they may prevent potential instability. Thank you for your attention.
Thank you, Dr. Dadufalza. Okay, we remind again everyone to please join the committees. The link is in your PSS Viber group. So once again, we will have Dr. Dennis